Gender disparity in healthcare. Why don't we take women's pain seriously? Atlantic writer John Fassler shared the harrowing experience his wife, Rachel, and how she nearly died because her pain was not taken seriously. Fassler describes his wife as a strong and logical woman, one who was not the type to sound the alarm over every pinch or twinge. He references a situation where she had once cut her finger badly enough to warrant an emergency visit, and explains that she had joked the entire drive to the hospital. So when he heard her cry out and found her in their bedroom doubled over in pain, he knew they were in an emergency. When the ambulance arrived to take her to the hospital, the EMTs had asked on a scale of 1 to 10 what her pain level was. Her response was an 11. Once they had arrived at the hospital, her husband panically approached a nurse, explaining that he'd never seen his wife in such a state. The nurse simply shrugged and told him she'd have to wait her turn. He goes on to describe nurses' reactions to his wife's crippling pain from dismissive to condescending, one having the gall to tell her, "You're just feeling a little pain, honey." By the time a nurse came to check Rachel's vitals, she was writhing in pain. The nurse had sighed, irritated, and told her to stop moving because she couldn't get a blood pressure reading. When Rachel continued to move, unable to contain the pain inside of her, she was restrained. The average emergency room patient in the U.S. waits 28 minutes before seeing a doctor. At John and Rachel's hospital, Brooklyn Hospital Center, the wait time is tripled, but Rachel's wait time would be longer than that. After several hours, around 10 a.m., the attending physician popped into her room. The encounter is described as so brief they had almost missed him. Only a few questions were asked, and no physical exam of any type had been performed. By this point, the healthcare providers had already written off Rachel's pain to kidney stones. This diagnosis was continued to be believed, and 45 minutes later, Rachel received standard pain management for kidney stones, and a CT scan was ordered. At 3 p.m., the CT scan announced Rachel was still writhing in unbearable pain, and during the CT scan was scolded by the lab tech, who told her to hold still so he could get a clear shot of her abdomen. When she asked for more pain medication, she was told, "A lot of patients to get to, honey. Don't cry." Men wait an average of 49 minutes before receiving analgesics for acute abdominal pain. Women wait an average of 65 minutes for the same thing. Rachel waited somewhere between 90 minutes and 2 hours. Late that afternoon, the attending physician had left, never seeing Rachel again and never reading her CT scan results. Frustrated and terrified of what may happen to his wife, John flagged down the replacement physician, hassling her until she checked the results. Finally, she acquiesced and was horrified to find that he never did an exam. He had been so sure of his diagnosis that he never checked the results, never put a finger on her. But the results were clear. There was a large mass in her abdomen. One, a doctor had explained later on, that could have been easily detected with some palpation. By this point, the ultrasound lab was getting ready to close. They were told if they couldn't make it to the lab before closing, they'd have to wait until morning for her results. They made it to the lab in time, but it wasn't until 8 p.m. that Rachel had gotten her results. Ovarian torsion. The mass had grown so large on her ovary that it caused the fallopian tube to twist, cutting off circulation and essentially causing death. The diagnosis can be deadly, resulting in organ failure, sepsis, ovarian loss, and even death. The best chance of salvaging a torsed ovary is surgery within 8 hours of when the pain starts. Rachel had waited a total of 14 hours before she received the surgery she desperately needed. She lost her ovary, but miraculously survived. Not only could Rachel's suffering have ended sooner had a provider taken her more seriously, but her ovary could have been saved with faster action. Unfortunately, her story is not unique. Women often wait longer than men in the ER, are less likely to receive higher priority status, and less likely to receive pain medication. One study found that men often saw a doctor sooner than women, with a difference of 11 minutes. The total lead time, or total length of stay, in the time from the patient's arrival at the emergency department until the patient leaves the emergency department, had a difference of 16 minutes, with men's total lead time around 3 hours and 46 minutes, and women's at 4 hours and 2 minutes. But ER wait time isn't the only thing women are shorted on. As John noted during his ER experience with Rachel, men are given analgesics more quickly and more frequently than women for abdominal pain. This is supported by a study conducted by Chen et al., who had found that despite having similar mean women were less likely to receive any analgesia and less likely to receive opiates. These differences persisted when gender specific wait time is the only thing women and after controlling for John noted during his ER experience, women are at an increased risk for chronic pain, and some evidence to 25%. According to Harvard Medical School, most A 2012 study on gender differences in cases of sepsis found that hospital mortality was higher in women as opposed to men. Women were less likely than men to receive deep venous thrombosis prophylaxis. Women were less likely than men to receive invasive mechanical ventilation, and women were less likely than men to receive hemodialysis catheters. There are numerous studies on gender bias and its effects out there, but even in the face of this scientific evidence, many ignore or rebuke these proclamations. But as healthcare providers, it's our duty to do our best for our patients, and part of that is taking in the facts and adjusting accordingly. Communication plays a major role in how our patients heal. By disregarding the pain women feel, by asserting that it's all in their head, and ascribing to the stigma that they are the weaker sex, we overlook very real symptoms, and perhaps even worse, degrade their humanity, severing the opportunity to build rapport and facilitate communication to improve recovery and compliance. Although alternative medicines and practices like crystal worship and sage cleaning may seem outlandish or even dangerous to Western medicine practitioners, the homeopathic industry is making a killing. And although one may assert that those that buy into these ideas are foolish or idiotic, it forces a bigger realization. The success of the wellness industry is a direct response to mainstream medical establishment that frequently dismisses and dehumanizes women. Although alternative medicines and practices like crystal worship and sage cleaning may seem outlandish or even dangerous to Western medicine practitioners, the homeopathic industry is making a killing. And although one may assert that those that buy into these ideas are foolish or idiotic, it forces a bigger realization. The success of the wellness industry is a direct response to mainstream medical establishment that frequently dismisses and dehumanizes women. Travis A. Weiss, a science historian at the University of Wisconsin, states that the doctor-patient relationship has been slowly eroding, not only with specialization and the fact that people now see panels of doctors, but because emergency rooms are slammed, there are insurance coverage problems, and so on. It can make a patient feel devalued. Enter the wellness industry, which specializes in creating safe, welcoming, amber-lit spaces that make people feel cared for and relaxed, and which treats the female body as its default. So how do we combat the current bias in our system? We start by listening to women. We fight the ingrained stereotypes and stigmas about them, and we listen to what they have to say. We practice due diligence as providers and look at the symptoms with the clinical mind, not the biased one. In practice, we would never shrug our shoulders at a patient who says they're out of breath and pass it off as they've just exerted themselves too hard. We assess them. We explore their health history. We talk about events leading up to the symptoms, and then we treat accordingly. As practitioners, we should also pursue a modified Hopkins checklist. The Hopkins checklist is considered a decision support tool, and it works like this. Whenever a provider is admitting a patient to the hospital, a computerized checklist pops up on screen. It asks if the patient has specific risk factors for blood clots or for bleeding from blood-thinning medication. Then the system offers a recommended treatment. By creating checklists for common risk factors, we treat the problem, not the gender. We must always remember we are healthcare providers. We always aim for the best rate of care for our patients.